I'm excited to speak with you today. In this talk, I'll look at some of the challenges faced by people with language and cultural differences and suggest some solutions because I don't want this to be a doomsday chat. Unfortunately, as you'll hear, multiple studies have found that if you have limited English proficiency or you're from a different cultural background, you are likely to encounter an entirely different medical system than an English-speaking insured patient. First, though, who am I to discuss equitable access to healthcare? For one thing, I've lived with chronic illness all my life. From childhood asthma, my mother having to rush me to the ER because we didn't have insurance, to a pituitary adenoma that causes hormone imbalances and led me to be diagnosed with diabetes insipidus. That's the opposite of diabetes mellitus. I also have 6 autoimmune diseases because, yes, I'm an overachiever, and ultimately experiencing a devastating brain injury that left me permanently disabled. Second, I'm a first-generation immigrant and the one to take my family members to countless doctors' visits. I was their sole interpreter. Third, in addition to being a nonprofit attorney during my entire legal career, I went back to school as an adult and am now a professor in narrative medicine, where I work with healthcare providers to learn the skills of close reading so they can better hear, interpret, and be moved by patients' stories of illness. The experience surrounding my brain injury was the impetus for me returning to school and pursuing a career in narrative medicine. I hope that my work helps shape doctors and that they in turn will provide equitable care for their patients. I've been around hospitals, doctors' offices, and the healthcare system my whole life. And if there's one thing I've noticed in both of my professions, not counting my career as an author, is that how we communicate in life and in our daily encounters is by telling stories. Whether it's through describing your coffee order to the local barista or recounting an interaction at the local pharmacy to a friend or family member, everything is communicated through a story, especially what is ailing our body. Imagine walking into an urgent care and desperately wanting to tell the nurse what hurts, but you don't speak the same language, or you only know how to say a few words. Now imagine how much more stressed and possibly embarrassed you would feel if you're un or underinsured. This was certainly the case for my abuela, my grandmother, who waited until she had stage 4 colon cancer despite being symptomatic. I was the one who noticed how pale she was, how dark her stool was, and took her to the doctor. I was in college, so I didn't regularly see her, and she died within months of being diagnosed. I was partly raised by my wonderful grandmother, who lived with multiple illnesses. She had managed to survive breast cancer, but was treated at a public hospital and was never offered the option of breast reconstruction. As most of my family didn't speak English, as I said, I was their primary translator at doctors' visits, but I was also a witness to all these doctor-patient interactions. I was the one who told my abuela that she had cancer because the doctor said he didn't have an interpreter. I was too young to insist that he get one, even if it was on the phone. As I just mentioned, I also grew up with my own set of medical problems. So I'll skip to the story and diagnosis that changed the trajectory of my life. While working as a public defender in the Bronx, I got horrible food poisoning, and it got so bad that I had to be admitted to the hospital for hydration. Pretty standard, right? I was given something called hypertonic saline, not as standard, which has 3 times the amount of sodium than a normal bag of IV. The doctor said it was critical that they draw my blood every 4 hours to check on my sodium levels to make sure that it wouldn't go up too fast and so that they could switch me to regular IV. During my intake process, my mother and I were speaking in Spanish, and my assigned nurse thought I should know that she disliked it when people came to this country but didn't learn the native language of this country, which according to her was English. My mother became irate. telling me in Spanish that I should list all of my accomplishments, my schooling, and everything I had already published at my young age. I didn't do what my mother wanted. Instead, I explained to the nurse that English isn't the native language of the United States, and that other than Native Americans who were already here and slaves who were forcibly brought here, the rest of us are immigrants. Now, the hospital personnel knew my complicated medical history, yet 2 entire days passed without anyone drawing my blood. My admitting doctor didn't even come check on me. I pushed the call button. I asked the resident doctors and the nurses. I even yelled into the hallway, "Hey, can someone please draw my blood?" I was told that it was summer, the hospital was understaffed, and that they get to draw my blood when they could, and I believed them. On the second night in the hospital, I felt disoriented. My entire body started to violently shake. I tasted my own blood from biting the inside of my mouth. I couldn't form a coherent thought. I couldn't call for help. I was seizing and I was dying. I knew I was, but all I could manage to do was pray. I wasn't ready to die. I waited on the doctors and I waited on the nurses, but they came too late. I had slipped into a coma. I awoke days later to be told it was a miracle I was alive and that I had permanent brain damage. I had to learn how to walk, talk, and take care of myself again. Some of the side effects from the brain injury included a seizure disorder, cognitive and memory problems, various speech impediments, movement and balance problems. Well, you get the picture. I was a mess. It took 6 years of inpatient and outpatient rehabilitation to get to where I am now. And I have no doubt that my being a first-generation immigrant, a non-native English speaker, impacted my medical care. The patient in the bed next to me, a white woman, was checked on regularly, both by the doctors and nurses. After the brain injury, my body was broken and my soul was crushed. The last people I wanted to see, especially while naked, under a flimsy medical gown, were the very people who had nearly put me in the grave. I had to put my fears aside and turn to medical professionals in order to recover. What choice did I have? I would have to show up informed, prepared to answer questions, and be hyper aware of the potential biases and prejudices that the healthcare providers would have about my ability to understand because of my memory and cognitive deficiencies, because I was uninsured until my Medicare benefits kicked in, then later because I had Medicare due to my disability. I got many inappropriate questions by medical staff about having disability at such a young age. It was a vicious cycle of feeling like an outsider, of being seen as an other. As I struggled to understand what the doctor shared with me about my brain and my recovery, I was both relieved and saddened to learn that I, along with most Americans, aren't health literate. Now, before I dive into the meat of the talk, dealing with language and cultural differences and the impact of, that population of patients have in terms of healthcare, I really want to talk briefly about the issue of health literacy. The studies have shown that people from all age, race, and income and education levels are challenged by an inability to obtain, process, and understand basic health information. An average of only 12% of the adult population has the skills to navigate and understand the complex US health system, skills that are reduced by stress and illness. 2 other studies came to the same conclusion as the ones on health literacy. Communication breakdowns occur even when patients and doctors speak the same language. The Robert Wood Johnson Foundation Project has come to view every healthcare encounter as a cross-cultural encounter. At least 90 million English-speaking Americans have trouble understanding complex texts common in healthcare. So who's included among those unable to comprehend typical health information? We're talking college graduates, teachers, and engineers. These studies concluded that healthcare environments have cultures of their own, ways of doing things and uses of language that are different than what average people, we're talking you and me, regular people, right? Of course, I'm sure in the audience, we're going to have a lot of healthcare providers, but that the average people experience in their day-to-day lives. Rarely are doctors asked to think about how patients discern meaning from the information they receive during a visit. So if medical terminology is difficult to process and understand for the average American, imagine how much harder it must be for someone who isn't from our culture and/or doesn't speak English. So what's the solution, right? There are health literacy toolkits that you can get online, and they are helpful, but the American Medical Association recommends that doctors put universal literacy precautions into place. What does that look like? It means that during a doctor's visit with a patient, they, number one, explain things without using medical terms. Number two, focus only on 2 or 3 key messages. Number 3, speak more slowly. And number 4, use the teach back method, which I'm going to explain in a second. And number 5, use easy to understand written materials. And quickly, my doctors have given me pamphlets that I open and then I say, have you even looked at this? This makes no sense to me. And they'll say, oh no, I've never looked at that. Just so, someone gave me these pamphlets. So look at the pamphlets before you hand them over to your patient. Now, going back to the teach back method, even if my doctors don't employ it, I make use of the teach back method by repeating back to my doctors what they said to me. I use this opportunity to ask any questions I've forgotten to ask, especially about any new medications. This is important because another study showed that 50% of physicians forget to tell patients the dosage of a new medication and for how long they need to take them. From my own experience, my doctors rarely share, they also forget to share any side effects of the medicines that the medicines may cause. That's why the patient must speak up and ask for clarification. And if they don't, the doctor must probe the patient to ensure all parties are on the same page. Now, let's talk about cultural differences and language barriers and what are some best practices. Now, first, I'm going to talk about lower quality care. So my research turned up multiple studies concluding that cultural differences and language barriers considerably hinder strong doctor-patient interactions among immigrant patients. Physicians tend to feel insecure in their patient communications because they are unsure of whether patients understand the discussion or they question whether the patient is properly articulating health issues. This leads to doctors adopting a more paternalistic approach to patient care, deliberately withholding information based on the belief that immigrant patients will have limited understanding. The doctors then tend to make decisions for their immigrant patients. This is all from multiple studies that have been done on different populations in different cities. So they're not just picking one city and repeating studies. Comparing patients with limited English proficiency to English proficient patients on various measures, patients with limited English proficiency have consistently shown to receive lower quality care in having an understanding of treatment plans and disease processes, overall satisfaction, and an incidence of medical errors resulting in physical harm, like what happened to me So let's talk about the use of an interpreter. Under Title VI of the Civil Rights Act of 1964, doctors who receive federal funds should provide competent interpreter services when needed. However, this legislation has not been strongly enforced. For example, one study found that 57 to 60% of hospitalized patients with limited English proficiency had communicated without an interpreter. Now that number is mind-boggling. Up to 60% of patients, either a doctor or nurse did not use an interpreter to communicate with these patients. There's a preference for ad hoc interpreters, a practice fraught with potential for errors. In practice, physicians may recognize that they are unintentionally providing worse care to patients with limited English proficiency, but justify it in various ways. Some of these are that someone else would get the full medical history, so I don't have to get it. They'll say, I'm short on time. Or, believe it or not, in the study, doctors will have said, the patient should have learned English. The research showed that if a physician or nurse's respective instructors didn't like to use interpreters, seeing them, for example, as a waste of time, then they in turn also don't use them. It's a case of healthcare providers liking to emulate their superiors. So now let's consider the patient's perspective. Nearly half of Spanish-speaking patients consider language barriers their biggest healthcare challenge, not only from communicating with their doctors, but from interacting with the healthcare system as a whole. Now, the bulk of the studies looked at Spanish-speaking patients because they have a larger pool to do surveys on. Even when translators of Spanish language versions of forms are available, patients may be reluctant to ask for or use these resources. The reason stated was because they largely rely on their friends and family to translate and offer health guidance. Spanish speakers were twice as likely to trust their friends and family's viewpoints, that was 40%, than information from English speakers, down to 22%. Immigrant patients are also reportedly reluctant to engage using digital or connected health technology. In some cultures, a face-to-face encounter is the only appropriate strategy for seeking medical care. Immigrants largely do not like to engage via telehealth or secure messaging, so it's critical to have good translation services. So, translation services. Translation tends to fall into one of three categories: simultaneous, line by line, or summarization. The latter being the least accurate, but most commonly used method in healthcare. When the patient and the doctor do not speak the same language, there is less opportunity to develop rapport or use the term small talk to obtain a comprehensive patient history, to learn relevant clinical information, or to increase emotional engagement in treatment. And the introduction of an interpreter may raise another set of questions. Unfortunately, most interpreters learn their trade through on-the-job training. Their language proficiency and how accurately intended meaning is conveyed from one party to the other is often not known. So I'm not suggesting we not use interpreters. Obviously, they play a critical role, but then how then do we know when an interpreter-mediated communication is effective? Doctors should be trained in working with interpreters. The more experience they have using interpreters, the better healthcare providers get at gauging whether they're good at their job. Some doctors' reluctance of using an interpreter can change, like when we change the custom of healthcare providers washing their hands before entering the patient's room. There was a time when that never happened, and now it's the norm. Speaking directly to patients requires active listening and engagement. Intermittent pauses necessary to allow the interpreter to convey the intended message. These can be opportunities to pay attention to facial expressions, gestures, or body language of the patient, and to create new ways to maintain a connection and cultivate a relationship with the patient. Active engagement can make the interpreter-mediated encounters more productive while humanizing the doctor's ability to communicate with all patients, regardless of language. Also, while using an interpreter, ensure you're doing simultaneous translation, not summarization. I want to note that while family members can help translate some communications, interpreters that are fluent in medical terminology are preferred. The lack of an experienced and qualified translator increases the risk of patients receiving improper care or not following through on their doctor's instructions due to a lack of understanding. I had a family member who thought they were diagnosed with cancer because they went with a friend, and the friend just did not know that they were being told that they had a cardiac issue. So they went from a slight cardiac issue that required having to take a medication to thinking for weeks until I could intervene and speak to the doctor that they had cancer. Busy healthcare providers might not pick up on the many cultural barriers that are difficult to observe, such as family roles, concept of justice, notions of modesty, core values, family values, and so on, all of which have been shown to influence the doctor's perception and approaches to health and medicine. So please, please, please use and work with an interpreter. Another issue that presents a challenge for people with language and cultural differences is lack of cost transparency. A big survey focused on low-income patients, Medicaid beneficiaries, the uninsured, and Spanish speakers as a way to identify patients who regularly face challenges in accessing care that meets their physical, personal, and financial needs. So what did they find? That 50% of patients were dissatisfied with their provider's price transparency, and 70% of uninsured patients stating there needed to be better cost of care information. Most of these patients consulted with friends and family on the matters of cost, further emphasizing the role that price transparency plays in healthcare access. So how do we fix this? Healthcare providers need to be fully transparent about the cost of care, and they need to do it in plain, simple language and prices, and provide this information in as many languages as possible. Now, the last thing that came up in my research is the perception of respect also presents obstacles to doctor-patient interactions, with 40% of low-income patients walking away from appointments feeling disrespected, adversely impacting their how this adversely impacts their care. Patients who feel disrespected are 3 times less likely to trust their providers and 2 times less likely to adhere to treatments than those who do feel respected. So if you're a healthcare provider, you should acknowledge and greet your patient. Greet their friend, relative, or caregiver who accompanied them. Build rapport with the patient. Include them in the decision-making. Explain everything in plain terms. Ask the patient to repeat it back to you to ensure they understood. Pay attention to their body language and your own. What are you communicating? Are you busy looking at your phone? Now, the electronic medical record, right? The bane of all physicians, Dave, explain that you have to take notes on the computer and that you're writing down what they're saying. Ask open-ended questions. Pay attention to your biases. Notice them and set them aside. And if you can't do that, then ask that another doctor take care of the patient. Try to put yourself in the patient's shoes. This helps build your empathy. The length of the doctor-patient relationship increases trust and communication effectiveness, so give it time. The longer you know a patient, the better the communication will get. And use an interpreter if there's any doubt that the patient might not be understanding you. There are countless cases where patients agree to a procedure or treatment, not understanding that their decisions couldn't be changed. And I'll just end by mentioning some online tools and trainings. There are various useful communication models that doctors can access online. One is an acronym, LEARN, L-E-A-R-N, which talks about listening and has the repeat back method and negotiating with the patient. They can also conduct a cultural and linguistics competence health practitioner assessment, and that's accessible through Georgetown University. And of course, healthcare providers can take cultural humility or cultural competency trainings. Cultural competency trainings have been shown to increase patient satisfaction, and they increase the likelihood that the patients will follow medical advice. I need to say, though, that no one can be fully competent. It's something that you keep striving for, and you keep learning, and you keep growing, and making those connections with your patients. And we should all strive to build equitable access to healthcare for all patients, regardless if they speak a different language or have a different culture. Thank you so much for listening.